Welcome to the episode 3 of AI for Healthcare Experts video course, where we describe simple but very accurate and applicable AI and machine learning concepts for clinical workflow. This video will be one of the most important in the whole course because we will talk about how really implement model to improve clinical workflow, how to make it economically profitable, beneficial, and at the same time not to increase clinical burden or make decrease quality of treatment. It's possible, and now we will discuss how to make it. As always, we start with a clinical task, classical for machine learning, and now it will be from very close to me topic, mechanical lung ventilation. Assume we have 50 ventilated patients, and they are in very different conditions. Some of them are already ready to be discharged, so we need to start spontaneous breathing trial. Some of them, oppositely, they are not very good, and we urgently need to make some intervention, change mode or make sedation or whatever else. And some of them just should be monitored as usual, like during regular rounds. And goal for AI model is to build system that will help to prioritize patients, that will show who is ready to be discharged, who is ready for spontaneous breathing trial, and whom we need to provide additional attention, additional support at this specific moment. Last time we discussed about results that AI models usually provide, and this result always can be true positive, so model adequately describes what happens. For example, it predicts deterioration, and indeed patient can be deteriorated. Some of results false negative, so model said that something is going wrong, and model said that everything is fine, and in reality something went wrong. So this is false negative, it's missed case. False positive, everybody knows false alarms. Model said that something goes wrong, but patient was fine. And true negative, model says everything is fine, and indeed everything is fine. So that's important to repeat because this basic concepts. And this is not something only for machine learning. So this example from study, review study of diagnostic accuracy of tests for assessing readiness for liberation for mechanical ventilation in adult patients. And we see that all the methods, they also have some sensitivity. So how many patients who really are ready to be liberated from mechanical ventilator were detected by this method. And we see that the best method still miss 6 out of 100 patients. What is perfect result, but this is pretty good result because other methods, they not so well. And lung ultrasound, it's some additional device, additional action that is required, and it's not something that can be done each time in each clinic, and it requires more competence from clinical staff. And specificity, so if this method said that patient can be discharged, so still 13 out of 100, they still become reintubated. And most of the methods that are simple or can be measured on the bedside just with ventilator, they are much less accurate. So they are even not in the table, so they are like much less accurate, less sensitive and less specific. So everything that we have for machine learning, it exists in industry for decades, and for all other methods. So sensitivity and specificity, false positive, false negative, this is not something that we have only for machine learning. So it exists all the time. But AI can increase these metrics. So this is a very famous study from Google and Stanford. This is rather old already. For AI, 2 years is already old study, but there were cancer doctors who should diagnose patients with cancer, and some of them were without AI and some of them were with AI support. And sensitivity were increased more than 6%, and specificity were increased almost for 5%. This is like for percentage points, so like more than 5% out of 75, so it's a little bit more than 5%. And this is maybe not so critical, but if you talk about like 10,000 people, and in reality it's much more, so still for like 100 we reduced stress, or we saved or detected cancer much earlier for additional 500 or 700 people. So this is significant. It's hundreds of saved people, and this is effect of AI. But we still need to choose a model. Usually it's some of trade-off. We can choose very sensitive model with many false alarms, and we can select very specific model that very accurate, but a lot of cases will be missed. So what should we choose? It should be something in between. What exactly in between? So last time we talked about Rockout curve. So that's exactly the point of this curve, where what thresholds we should use for our model. And there are methods how to define it accurately. And one of the obvious approach is cost-based approach. So we just calculate the cost of false positive, false alarm. It can be additional diagnostics, it can be additional workload. So something, it's additional time of people, time in hospital, and it can be measured, of course, in money. At the same time, we can calculate cost of missed cases, more expensive treatment if we start treatment later, or it's more serious deterioration. So we calculate cost of false positive and cost of false negative, and then we find out the best combination that is the most. And of course we also can compare it with how it happens now, because maybe AI will make things worse and we don't need to use it. It's also the case, it can be the case sometimes. And based on like purely mathematics and financial analysis, we can find the best threshold how we will use our AI model. So this is our example for cost-based approach. So assume we have price for missed case, like for false negative, $1,000, because it means we start treatment this patient much later. So it can be or hospitalization, or for instance, it's much longer. So we miss the moment when patient start deteriorating, and we had to make urgent intervention. We didn't do it. It led to like prolonged length of stay. So in reality, it can be even more expensive for lung ventilation. It can be like 10, $15,000 just because of prolonged length of stay. So at least for our example, it's 1,000. Now, cost of false alarm, like usually each much this price is much less. The bad thing with false alarms, if there are too many of them, clinical staff of course are not happy with this, and people just start ignoring alarms just because it's impossible to react on everything. And as we know, that's a huge problem in intensive care. Like 60 to 90% of all alarms from monitors, they are false. And sometimes, what we know, a lot of times nurses are trained to just ignore alarms because it's impossible to work if you always hear this beeping. But for this moment, we just want to evaluate it with some price. So assume $50, and like assume this is like model like legacy without AI, or it's old AI model. So this way we can compare different AI models. This is also quite interesting. And so this is our what we choose regarding our threshold. So our threshold is here, for instance. And this is our metric. So it's pretty good case. So assume our model is good. And that's how before AI, so we had 24 missed case, like total cost because of missed case got total cost $24,000. With AI, we have less false alarms, only 17, and only 3 missed cases. So basically, these are 3 cases that we missed, and like with blue, that are that are false alarms. So 17 of them, and so we avoided 21 case. This is significant. Because of this, we saved 21,000 euros, and we need to decrease cost of false alarm. So for this specific case, we saved for hospitals $20,000. So this is pretty good result. Assume we have very high, so low tolerance for false alarm cases. So assume we have like 500. So missed case cost 1,000, but false alarm cost 500. And we already saved much less. And let's try to switch our threshold a little bit. So for instance, so we can change our threshold to change amount of false alarms or missed cases, and we see that this is so we need to choose 1305. So yes, that was the best case. So we changed a little bit threshold, and this is like the best case for us. Assume like we have the same price for false negative and false positive. So in this case, still our model works well, but we need to change, I guess, change threshold a little bit more. Well, maybe not. So still, this is the best case. So for this moment, it doesn't matter. Assume we have more price for false positive, and that's a way how we can do it always. So now, by the way, this is the case when because of we have a lot of false positive alarms, we saved $21,000, but we saved some money. We saved 21 multiplied 500, so 10,500, but we lost 18 because of false alarm. So we need to reduce false alarm as possible. So how we can do it? It's almost impossible. So maybe in this case we cannot. Yes, for this case, for instance, our model like useless. So that's the best case what we can do, and even in this case it doesn't work. So that's reality, and that's how we can calculate things, and that's how we can evaluate what model is good for us, what model is bad for us. So that's simple model that help us, and obviously this is pretty good metrics. It can be much worse, and then but idea how we will evaluate this model comparing to business as usual is pretty the same. So we just calculate false alarm and false negative results, and we calculate what threshold is better for us. So do we need to reduce sensitivity or reduce specificity? That's how it works. Another approach is using multiple models with different thresholds. So more accurately, we use the same model, but we have different thresholds, but we use it multiple times. And in this case, we we use model with very high specificity that detects the most urgent cases. We also will show it on the model, so it will be clearly for you to see how it works. But the idea that we choose urgent cases, that even that model that miss a lot of cases, but it still almost doesn't have false positive alarm. So if it says that there is a problem, it's indeed a problem. So we use this model to highlight urgent cases. Then we use a very sensitive model that usually it detects almost all the cases. A lot of things that this model said, it will be healthy patients because it has very high sensitivity but low specificity. So a lot of false positive alarms. And we use it another way. Patient that this model said that are healthy, it's almost 100% that they're healthy. So we also don't need to spend time on them. We know that they are fine. And only something in between we have to review manually. So this some kind of compromise, and we will see in our model that it's possible to reduce workload like at least twice, but sometimes it can be like 3 times, 5 times, and that's still very safe and very cost efficient. So let's go to this example in our model. That is how it may look in real world. Like assume we have 50 patients in our ICU, and we have model that with the threshold 50%, like for instance, has 90% sensitivity, 90% specificity. So quite a good result, but still there are false positive and false negative. And we're not satisfied with it. We want to know exactly which patient, for example, our model should predict, can we discharge this patient from ventilator or not. So, and we want to be 100% sure whom we can discharge and who we cannot. And this is possible for some of the patients. So we may have, we can apply model with a threshold 80%. And it means that this patient should not be discharged because it's almost certainly, maybe with a mistake like 1 in 10,000, this patient will be reintubated. So we do not discharge them. We know this based on our previous experience. We know that when model says 80% risk at least, then no discharge. It always will be reintubation. So there are not so many such patients in our among our 50, but for this we exactly know what to do, and this is already quite well. We apply the same model but with a threshold 20%, and we say that these patients, so how many of them? 1, 2, 5, 9. These 9 patients can be discharged. So no risk for them. We know this based on our experience. When risk of reintubation less than 20%, then it's almost certainly, like again, 1 in 10,000 will be an error, but almost certainly they are fine. So we had 50 patients, now we have only 37 to review, and for these 13 we know exactly what to do. So if it will be 500, it's a significant reduction, so it's almost 30% reduction of our workload, and it's almost 100% assurance that this should not be discharged and this can be, because thresholds are set in a way that almost never make a mistake. So that's how we can apply one model 2 times to get 30% reduce of cognitive workload and without false positive and false negative. Yes, for these 37 patients, we need to implement other methods. We need to think more about them. We can use our model, or we can use additional, for example, ultrasound, or we do another diagnostics to define, like, are they safe to discharge or not. But for 30% of the patient, we do not need additional diagnosis. We already know what to do with them. And that's the benefit of usage AI in collaboration with humans. So, as a summary of what we discussed today, all methods of diagnostic have some sensitivity and specificity. Not only AI, so it's not something new, it was for decades. What we know, AI can increase accuracy of existing methods, so it can increase sensitivity, increase specificity, reduce false alarm. So that's already proven in literature, mainly for computer vision, for cancer diagnosis, but I expect that more and more it will be in other sectors, including prediction of heart attacks or deterioration, or what we work on is prediction of reintubation failure, or in general any healthcare events. It will be possible to reduce amount of false alarms and predict more accurate things that we want to know in advance. Second thing is we can choose right threshold for the model, right accuracy or right sensitivity and specificity based on the costs of additional treatment of false alarm or missed case. So based on this purely economical or clinical workflow, we can define the right thresholds. And we can apply the same model with different thresholds to identify with a very high certainty healthy patients and patients that require more our attention. So that's another methods that can help to apply in real world AI. As I said, this is incredibly important topic, incredibly important video. I hope I was able to describe it in understandable way with examples, with some models, and how thresholds can be adjusted because of different costs. And next time we will discuss one of the favorite words of officials in Europe, bias. Also important question, and we will understand why it happens and how to mitigate it. Again, please provide your feedback, provide your comments, questions, what you like, what you don't like. If you like it, please share with your friends, share it with your colleagues. If you don't like it, please tell me what we can do better, and we will do. Thanks for your time. See you next time.